If you're a healthcare professional interested in the treatment of leg spider veins by microsclerotherapy, this video is for you. This is the practical heart of microsclerotherapy, the injection technique itself, and how to manage your patients after treatment. This tutorial shows what sclerosant to inject, the mechanics of safe and accurate injection, common technical challenges, and the evidence-based approach to aftercare, including the controversial topic of compression therapy. And be sure to stay to the end, where I will tell you about 2 new topical treatments which you can apply to help reduce that really annoying and common problem of brown pigmentation and staining after microsclerotherapy. Let's dive in, and let's start with understanding what medications, the sclerosants themselves, that we're actually injecting. The 2 most commonly used sclerosants worldwide are polidocanol, known as POL or ethoxysclerol, and sodium tetradecyl sulfate, known as STS or fibrovane. Both are detergent sclerosants, and they work by lysing the endothelium of the vessel, triggering inflammation and eventual fibrosis and reabsorption of the vein. The key difference between these 2 is strength. STS is 2 to 3 times more active than POL, so you must adjust concentrations accordingly. For telangiectasias, European guidelines recommend 0.1% to 0.2% STS or 0.25 to 0.5% POL. For reticular veins, use up to 0.5% STS or 0.5 to 1% polidocanol. Both sclerosants are prescription-only medicines in the UK, and you must be able to manage anaphylaxis if you're going to use them. Once you understand the sclerosants, the next critical element is accurate injection technique. Successful microsclerotherapy depends on precise, accurate injection technique. This minimizes complications and it maximizes good results. The principles are simple but non-negotiable. Inject small volumes of the lowest effective concentration. Inject slowly and gently. Constantly check that there's no extravasation, and if there is, stop immediately. You'll know if there's extravasation because you'll see a bleb. It'll be painful. And stop immediately if you see blanching of the skin around the injection site. Remember, you're aiming to blanch the vessel, not the skin. Blanching of the skin is a warning sign to stop immediately. I have a mantra that I teach all my students. Low, slow, low, low, hold. This is an aid to remember to inject low volumes at each injection site, that the injections must be slow, the concentration should be low, and that the injections should be delivered with low pressure. And at the end, you should hold the sclerosant in place for 10 seconds before removing the needle. Let's break down the specific technique for injecting telangiectasias. Telangiectasias lie in the upper dermis, so they're very superficial. The common mistake that's made initially by beginners is placing the needle too deep. I use a 30 gauge needle and I bend it to 15 degrees with the bevel upwards. In this way, you can place the needle flat on the skin and advance it slowly with gentle pressure on the plunger. You'll see small drops of sclerosants leaving the needle even before it punctures the skin. Success is confirmed by blanching of the vessel. Limit the area treated to about 2 centimeters by 2 centimeters for any single injection site. If a bleb forms, or if there's blanching of the skin, or if the patient feels any pain or discomfort, stop immediately and watch very carefully the tip of the needle as you do the injection. With telangiectasias, aspiration is not possible or even appropriate because the vessels are too small. You're relying on visual confirmation of blanching to know you're in the right place. Let's look at some examples of injection technique. Now here you can see Kathy McGuinness doing an injection, and we can see that she's bent the needle, she's injecting very slowly, and she's getting blanching of the vessel. This is a successful injection, and she then applies pressure on the area to hold the sclerosant in place, as well as to massage the area and disrupt the endothelium and disperse the sclerosant. Let's just watch that again. The needle's bent, the injection's slow, and the vessel blanches. That's a successful injection. Now, this is another injection being demonstrated by Kate England. She uses a slightly different technique. The needle is not bent, but the skin is stretched, and success is shown by blanching of the vessel. Let's watch that one again. Slowly advancing the needle, slow pressure on the plunger, blanching of the vessels while stretching the skin. A great example by Kate England of a successful injection. And here's another example by my colleague Zola Mazimba. Different technique, a slightly bigger needle, a blue needle, but again, the skin is stabilized and stretched, and success is identified by blanching of the vessel. Let's watch that again. And note that the ankle is not an area for beginners to inject. There are a lot of neurovascular bundles nearby, and this is only an area that advanced practitioners should tackle. Now, reticular veins require a slightly different approach. Reticular veins lie just deep to the skin at the junction of the dermis. So as the sclerosant is injected, the needle angle is not flat on the skin. Instead, it is about 5 to 10 degrees. Most practitioners use a straight needle for reticular veins, though in the demonstration I'm about to show you, my colleague Kathy McGuinness uses a bent needle. Now, because these vessels are 1 to 3 millimeters in diameter, you can confirm needle placement by gently aspirating to see dark venous blood coming back into the syringe or into the barrel of the needle. You don't want to aspirate back into the syringe because blood inactivates the sclerosant. Once you've confirmed that you're in the vein, inject slowly up to a maximum of 0.5 milliliter for any single injection site. Stop if you feel resistance, if the tissue becomes raised, or if the skin around the vein blanches. And consider holding pressure on the syringe for about 10 seconds after injection without injecting any more sclerosant. This may allow for longer contact time between the sclerosant and the endothelium before it's dispersed and washed away. Let's look at an example of successful reticular vein injection. This is my colleague Kathy McGuinness. She does have the needle bent. It's a 30 gauge needle. The needle is at 15 degrees to the skin, and she successfully injects into a reticular vein. The skin is held tight and taut by stretching the fingers apart. Here's another injection of a reticular vein, and there is successful blanching of the reticular vein. Here we see Kathy identifying the successful reticular vein injections and how the sclerosant has dispersed into the Telangiectasias. This is quite a long video, but I think it's worth watching because it shows some really nice injections of the reticular veins that Kathy is so good at. There we are. Lovely injection. Beautiful. blanching of the reticular veins. There we are, such a beautiful demonstration of blanching of the reticular vein there by Kathy McGuinness. And again, she likes to disperse the sclerosant and agitate the endothelium. That was a bleb. You can see there a bleb that's formed. That wasn't a successful injection, but she moves to a slightly adjacent site and gets successful blanching. There we are. This is Kathy showing her rather unorthodox technique. She uses a 1 ml syringe and she's using her index finger to apply pressure to the plunger of the syringe. There we are. Another lovely, successful injection of reticular veins. Beautiful demonstrations. And massaging the area seems to help break that endothelium. The membrane has been disrupted by the sclerosant within a few seconds of injection, but massaging the area and applying some pressure with a swab helps disperse the sclerosant and helps disrupt the endothelium further. This is Kate England showing how she does her injections. Note how she uses her index finger to support the needle hub, and she uses her other fingers to stretch the skin. Very nice, accurate injections of reticular veins. Beautiful demonstration by Kate England. Everyone has their own technique, but stretching the skin is very important, and stabilizing the syringe and the needle hub are also vital. Poor positioning causes neck and back pain for you and causes discomfort for your patients, and both will shorten the treatment session and reduce accuracy. I suggest you start on the lower anterior leg and work systematically. To treat the sides, ask your patient to lie in the recovery position facing away from you. This allows you to treat the lateral surface of one leg and the medial aspect of the other. Systematically ask your patient to turn, and that way you can cover all the areas of the leg with minimal discomfort to your patient and minimal discomfort to yourself. For the back of the legs, ask your patient to lie prone. Work on the leg nearest to you, then move yourself and your stool around to the other side of the couch. Use an adjustable height couch, a stool on wheels, and a mobile work surface. Your comfort directly impacts your precision and your stamina during longer sessions. Even with perfect technique, you'll encounter common difficulties. Let's address those now. Bleb formation indicates extravasation. You've injected sclerosant outside the vessel and into the dermis. This is quite a common problem and quite frequent in the early stages of learning, and even experienced practitioners have runs of blebs. With practice, this should happen fewer than 1 in 20 attempts at injection. If blebs continue to be a problem, review your technique. Are you bending the 30-gauge needle 10 to 15 degrees with the bevel up? Are you stretching the skin flat? Is the needle truly flat on the skin? Are you advancing slowly with slight pressure on the piston? Consider enlisting an assistant to stretch the skin for you and give feedback on your technique. Video recording your technique can be invaluable for reflection, but get consent and maintain confidentiality. Here's an example of even an experienced practitioner getting a bleb. So we're advancing the needle towards that small, very fine vessel. And unfortunately, the skin is raised. We can see that the skin is distorted. It's white, and that is a bleb. Let's just have another look at that. It's important that you can recognize blebs. As soon as you see a bleb, and you should be watching the tip of your needle at all times when you're injecting. If you get a bleb like this, if the skin is raised and you get that's a bleb, you get white blanching of the skin because of the presence of clear sclerosant, then that's a bleb. What you should do as soon as you recognize a bleb, stop immediately, massage and disperse the sclerosant. If you're using very low concentrations of polydocanol, 0.25%, and you identify a bleb very early on and you disperse it with massage, you shouldn't have any problems. Immediately after injection, the area looks really quite frightening to some patients. It will look inflamed, it will look bruised, and the injection sites may be itchy and sore. I have a routine to apply steroidal cream, but you could apply an antihistamine cream, and you could suggest to your patient that they buy an antihistamine cream over the counter. So it does look quite scary. It's good practice to keep your patient in the clinic for up to 30 minutes. Give them a cup of tea, get them to walk around, and show them the ankle movements they should be doing in the waiting room after the treatment so that you disperse the sclerosant. Make sure you give post-procedure advice both verbally and in writing, and make sure the patient knows how to contact you or the clinic if there is a problem, and confirm the follow-up arrangements before they leave the clinic. Compression therapy after microsclerotherapy is one of the most debated topics in phlebology. Medical compression stockings after sclerotherapy are widely recommended, but the evidence supporting their routine use for cosmetic thread veins is, in my opinion, very weak. The 2023 consensus statement from the International Union of Phlebology gives compression a grade 2B recommendation. The use of medical compression stockings after liquid sclerotherapy of C1 veins to achieve better outcomes. That's a weak recommendation based on moderate quality evidence. Some studies show that compression reduces thrombus formation and improves vessel clearance. But interestingly, patient satisfaction scores are no different. Compression has no proven effect on pigmentation or matting. So what do you tell patients? Well, in my practice, I explain that compression is controversial, that there is some evidence of benefit, but that I don't routinely prescribe it for simple cosmetic thread veins. If a patient has had poor results previously, such as pigmentation, thrombus or matting, I may recommend compression. Regardless of compression, there are core aftercare principles that everyone should follow. After microsclerotherapy, patients should be encouraged to remain active and keep well hydrated. Walking promotes flow in the deep veins and it reduces the risks of thrombosis. I advise patients to avoid long-haul flights immediately before or after treatment. And I'm cautious about treating patients with a history of venous thromboembolism or known thrombophilia. Patients need to understand that their veins will look worse, as we've discussed before. They will look worse before they look better. Bruising, redness, and visible clot within the veins are all normal. The healing process works by destroying the endothelium, triggering fibrosis, and this takes weeks. Set clear expectations for improvement. They're not going to get perfection. Arrange follow-up at 6 to 12 weeks and consider offering early review at 2 weeks if you want to release intravascular thrombus to reduce pigmentation risk. Not everybody does that, and it does have cost implications, and patients don't like it. It's uncomfortable. Follow-up and repeat treatment are where you build long-term relationships and results. Microsclerotherapy is a staged process. As some have explained, it's not a one and done. Most patients need multiple sessions spaced 6 to 12 weeks apart. At follow-up, reassess the areas treated, photograph the results, and plan the next session. Address any complications early, such as retained coagulum, which can be released with a needle, and early pigmentation may respond to targeted treatment. Use an open appointment system, if possible, where patients can book their next session when they're ready, rather than being locked into a fixed schedule. This respects individual healing rates and builds trust. Document everything. What you injected, where you injected, the concentration, the volume, the patient's response, and your plan for the next session. Good records protect you and improve your reflective practice. Let's address the most common complication that worries patients: pigmentation. Some degree of pigmentation is inevitable as part of the healing process, but excessive pigmentation, or pigmentation that extends beyond 6 months, is a problem. It occurs if the sclerosant strength is too high, if there's unrecognized superficial venous reflux, if there's persistent reflux in a reticular vein, or if there's excessive thrombus formation. To reduce the risk, use the lowest effective concentration. Check carefully for reflux with the handheld Doppler, and look again for reticular veins with transillumination, and consider whether compression on a subsequent session might help. Seeing patients routinely at 2 weeks to reduce intravascular thrombus can reduce pigmentation. If you see pigmentation, reassure them that most pigmentation resolves within 6 to 12 months, but document it and manage expectations. Recently, I've become aware of 2 topical agents that may help reduce hyperpigmentation. The first is thiamidol, a reversible, highly specific, non-toxic tyrosinase inhibitor available without prescription. My colleague Kathy McGuinness has brought myself and other members of the British Association of Sclerotherapists attention to this, and the evidence for it is available on the BAS website. I'll put a link in the description box below. The other is Angiogel, which removes iron deposits in the skin. I will put links in the description if you're interested. Thiamidol works by blocking tyrosinase and melanin production, and post-inflammatory melanin production is one of the factors that leads to staining and pigmentation. The other is iron deposition, and Angiogel is a chelating agent, and it is said to remove the iron deposits in the skin and just below. So both of these products have personal recommendations. If you have personal experience, I'd be interested in your views. Again, you can leave a comment in the description box below and tell me of your experience. Finally, let's talk about when things go wrong and when to refer. Major complications are rare, but you must be able to recognize them and act quickly. Skin necrosis from extravasation or from veno-arteriolar reflex vasospasm or from intra-arterial injection is a catastrophe. If you see intense pain on injection, if you see blanching of the skin, or if you see a bleb, stop immediately and massage the area. This will disperse the sclerosant. Document what happened and consider early referral. As I've said before, bleb formation is quite common, and provided you're using a low concentration of sclerosant and you recognize the bleb early, so you only inject a small amount of sclerosant outside the vessel, blebs won't cause any skin loss. However, if you see the skin turn white because of veno-arteriolar reflex vasospasm, then you need to stop immediately. That's usually very painful, and that may lead to a small area of skin necrosis. If you inject a small artery or a small arteriole, that is a major problem, and really the only thing you can do then is to call 999 and get that patient referred to a hospital as quickly as possible. Allergic reactions are another emergency that require immediate management. You must have emergency equipment and protocols in place before you start treating patients with sclerosants. Neurological events, these are actually a type of migraine. Stroke and TIAs are not really an issue, but migraine and the aura and symptoms of migraine can be very misleading and very worrying. So you do need to warn your patients that they might get a headache, they may get some visual disturbance, they may get some symptoms down one side of their body. This is not a stroke. It's not a TIA in the sense that it has the same prognostic indications of an impending stroke. It's a form of migraine, and my colleague Alessandro Frullini has written extensively about this. It's a form of migraine caused by endothelin, which is released when the endothelial cells are disrupted. DVT and pulmonary embolism are extremely rare, but they are serious. They are minimized by using small doses of sclerosants in one session and getting your patients to do ankle movements and to get moving as quickly as possible after the treatment, that they stay well hydrated and keep moving. I do think it is good practice to observe your patients for 30 minutes after treatment. Give them a cup of tea, ask them to wait in the waiting room, get them to do ankle movements while they're drinking their tea. Make sure they know how to contact you urgently if symptoms develop. Know your limits. If you're not confident about managing a complication, then refer early to a vascular specialist or a phlebologist. Let's summarize the key learning points from today's session, from today's tutorial. Successful microsclerotherapy depends on understanding your sclerosants. Use the lowest effective concentration. Master precise injection technique. Inject telangiectasias superficially. When you're starting, bend the needle. Inject reticular veins at a shallow angle and consider aspirating. Blanching of the vessel confirms success. Blanching of the skin is a warning to stop. Position yourself and your patient for comfort and accuracy. Troubleshoot common problems systematically and change needles frequently. After the procedure, observe your patient for 30 minutes. Give them clear aftercare advice and manage expectations about the healing process and the timeline for improvement. Compression therapy is controversial. Discuss it honestly with your patients. Follow your patients up at regular intervals, 6 to 12 weeks. Document meticulously and build a staged treatment plan. Recognize complications early and refer when needed. Mastering these principles will allow you to deliver safe, effective microsclerotherapy and build a profitable, low-stress cosmetic vein practice. Well, I hope you found this video helpful. If you did, give it a thumbs up and a like. Don't forget to check all the links in the description box below. Consider subscribing to my channel. That way you won't miss my next video. Thank you for watching.